All right, good afternoon, everyone. My name is Rosetta.
And I'm Kelsey.
Today we're going to be talking about lactation mastitis. We're going to be going over some disease information and a very interesting current research study. So before we begin, let's first talk about what is mastitis. So mastitis can be generally divided into two separate categories. We have non-lactational and lactational. Today we'll be specifically talking about lactation mastitis. But before we get into that, why be concerned with lactational mastitis? Well, it affects 2 to 11% of breastfeeding women. And it can also lead to cessation of breastfeeding, which is associated with increased incidence of infectious morbidity, elevated risk of childhood obesity, type 1 and type 2 diabetes, leukemia, and sudden infant death syndrome. So this is why it's really important that we just talk about this and discuss management and treatment of lactational mastitis. So a bit of background, lactational mastitis is defined as inflammation of breast tissue that involves some kind of bacterial infection. It affects women who breastfeed, and it can occur at any time during lactation, but it most commonly occurs in the first 6 weeks of breastfeeding. So some causes: prolonged engorgement of milk ducts, inadequate draining of milk, and then additionally introduction of bacteria that prolong the skin. So generally we'll see the strain Staphylococcus aureus commonly. So essentially the mechanism for how this works is stagnant milk in milk ducts leads to growth of organisms, which then leads to infection, or bacteria from the mother's skin or the baby's mouth gains entry to the mother's milk via cracks in the milk. And then some risk factors include a prior history of mastitis, poor milk drainage, and cracked nipples. And then some symptoms and signs. So a patient will present in the clinic with firm, painful, and swollen area on the breast. It can also look like some kind of lump or abscess. A wedge-shaped redness is also very common, and it's typically unilateral. She can also present with fever, diminished milk secretion, and then just overall flu-like symptoms, feeling very bad overall.
To test this, you can look at white blood cell count or bacteria count in the milk. And to do this test, you have to first practice proper sanitation, so like wash your hands and wash the breast of your mother. Then you're going to manually pump the milk, discard the first 3 milliliters to ensure consistency in the sample, and then microscopically analyze the sample. And from this, you can see if there's a significant number of leukocytes or white blood cells, and if there's a significant amount of bacteria. And if there are, then that's a clear indication that the patient could be presenting with mastitis. To treat, I know this looks like a lot, but essentially it's just pain management or antibiotics. So first, if you don't have infectious lactational mastitis, you would practice the pain management route by doing effective milk removal, which is getting rid of this overflow of milk to avoid overfilling in the breast and to help relieve some of the pressure. You can also use like a hot compress before or a cold compress after breastfeeding in order to help with pain management, as well as using some over-the-counter medicines. Of course, rest and water is helpful anytime your body is showing some sort of illness. And ensuring proper nursing techniques could be a good way to try to fix this mastitis presenting itself by ensuring that your baby is nursing in a good way for you. So changing that can be helpful. However, if you start to see fever or a breast lump that stays for 24 hours, then this is time to consult your doctor further for a potential antibiotic. Because if you end up getting infectious lactational mastitis, this is when you need antibiotic therapy for approximately 5 days. But you would also continue to use the same pain management techniques that I just stated. In some really rare cases, you may require surgical drainage of the abscess, but again, that's pretty rare. So while this is painful and uncomfortable and generally not pleasant, lactational mastitis does not cause any long-term problems, and with proper treatment, it generally clears up after about 10 days, especially if you're taking those antibiotics that are like a 10-day antibiotic. And milk production will increase as the patient begins to feel better. So keep that in mind.
Okay, so now we're going to talk about a very recent study involving the use of probiotics rather than antibiotics for the treatment and management and prevention of mastitis. So essentially, the researchers in the study did a review of health consequences of antibiotics, which includes resistance, disturbance of the human GI microbiome, and as well as GI, urogenital, and oral infections. So they actually found that a certain strain of probiotic isolated from the milk of healthy women is very good in managing mastitis and can be something positive for the treatment and prevention without the use of antibiotics. So the big guiding question in this study was, can oral administration of the probiotic during both late pregnancy and lactation reduce the risk of developing mastitis in lactating women? So that's what they were looking for in the study. So this study was conducted by Jimenez et al. Over the course of 3 years. It was a randomized placebo-controlled trial. So essentially, one group received a daily oral dose of the probiotic from the 35th week of pregnancy to week 12 after delivery, and the second group received a placebo. And then some inclusion criteria included healthy pregnant women of at least 18 years between the 33rd and 35th week of pregnancy with the intention to breastfeed. Exclusion criteria included, they had to be within a certain BMI range, use of probiotic supplements during the 3rd trimester, enhanced chances of premature delivery, or current or previous severe illnesses. So if they had any of these, they were excluded from the study.
So as we stated before, the subjects of the trial were either randomly assigned a probiotic or a placebo in a 1 gram sachet to ensure consistency, and they would be able to tell which one they were receiving. And these were assigned at the first visit. In addition to this, they were also required to go to 2 other visits and talk on 2 phone calls. So we had like the first visit at the beginning of the study. Visit 2 would be a week after the delivery. The phone call was 6 weeks post-delivery. And then the 3rd visit would be 12 weeks after delivery, and phone call 2 was 2 weeks after the last supplement. And the point of these visits and phone calls was to report any breastfeeding activity to ensure the number and how it was going, and also any potential mastitis symptoms. That way they could gauge if further treatment was necessary. So as we look into the results, this is how the different groups were divided. We initially started with 328 subjects, and after randomization, we had a pretty even split in the categories of either the probiotic or placebo. However, some exclusions came in, such as like people dropping out or not taking the supplement they were given, and this led to a slightly favored probiotic category. So some results that were very interesting to us was this graph of statistical analysis, and it shows clearly that there is a difference between the placebo and probiotic group. The chart on the left is showing that the placebo group is going to have a higher proportion of subjects with mastitis. I know it can be kind of confusing because the scale is free of mastitis, so the higher number is actually good in this case, and the probiotic group has the higher number of being free. And then the graph on the right is showing that the probiotic group has a less likely chance of developing mastitis overall. And this is based on a statistical analysis of different risk factors and how they will affect their development. And additionally, this table really kind of sums it up well with the actual reports of mastitis. Of all the subjects in the study, there were only 31 that reported to have signs of mastitis. But this also shows a significant difference with the placebo and probiotic group, because there were only 9 in the probiotic group and 22 in the placebo. Some other important parts of this table is that the placebo group had 73% using antibiotics, while the probiotic group only had about 44%. This is quite the difference, especially considering antibiotic use is harmful for both the mother's natural gut microbiome, as well as passing it on to the infant. So this clearly shows that there could be a way to prevent this antibiotic use during nursing. And yes, you can see in this table that there's an uptick in anti-inflammatory drug use for the probiotic group, but this could be assigned to the case that they aren't using antibiotics, so they'd have to manage their pain some other way. So yeah, that's all. Any questions?
I had is at the beginning of the presentation you said that it was like 2 to 11% of women who were affected with this. I was wondering kind of like why that estimated rate.
Based on the research that I found, it didn't really have a specific number. It was always a range. So that was the most recent statistic that I found.
The reason you see ranges like that, for instance, is because you'll have I don't know, 3, 5, 7, 10 studies that have been done on incidence. And so they literally go from the one study that had an incidence of 3% to 10%, and that's why they reported that way. So there's just multiple studies basically of small subsets of people, and so that's why these you'll see variables like that.
The other thing is like, this is often a condition that just by continuing breast pumping, the patients get better. So it depends how vigilant when you're doing a research study like this, like how closely you're actually looking for the outcome in your population.
I mean, because you'll see ranges sometimes will go like 3 to 80%. You're like, what is going on? They're like completely different studies, and that's why ranges exist like that.
How do the ingested probiotics reach the breast?
Question, I'm not really sure on that, but if I had to make an assumption, it would be that if you're digesting the probiotic and it's storing natural bacteria, it's probably making its way into your body's microbiome. And then there's a direct connection between your gut microbiome and other parts of your body. So that would be my assumption, so that it just naturally.
I think one of the issues with probiotics that is like tough to study is like the evidence is like very mixed, but in general, like when you take any type of probiotic, like it gets like everywhere. So like even when you're like ingesting something that comes out in your stool, I know that sounds gross, but like this stuff gets everywhere. You can kind of think of it just like bacteria that's on your skin. So how much of that makes something clinically, impacts things clinically, I think it's hard to say, and we're still just trying to understand that.
Thanks.
Yeah.
Great. The other thing I'll say with this is that the big thing, I think you touched on this, is that breastfed babies, their microbiota looks different than non-breastfed babies. That's like the biggest, probably, kind of the biggest impact.
Yeah, you guys didn't touch on this at all, but breast milk is bioactive. It has white blood cells, immunoglobulins, and lots of other proteins and chemicals that are not found in formula. And so obviously we want to do everything we can to improve breastfeeding, but that's not
Yeah.
where we stop.